think my audio is on. Hello. Just give the video a minute to come on. Hello. Okay, I think we're live. Yeah. Okay. So good morning. Last week we had started the development of the central nervous system, and we had dealt with different parts of it, and we had come up to corpus callosum. So today I'll attempt to close that, finish the development of the nervous system, and then go into special senses, of which we will look in detail at the development of the eye and the ear, or the hearing apparatus. The special senses also include taste and smell, but we won't be dwelling too much on that. Taste buds are a derivative of the local epithelium of the oral area, just like the surface of the tongue, the inside surface of the cheek, the undersurface of the palate, and so on. There's not too much complication there. It's easy enough, and it's a less important part of your undergraduate curriculum. Olfactory epithelium, especially nowadays in the days of COVID, when loss of smell is a big deal. Olfactory epithelium does not usually have a congenital difficulty, a basis of maldevelopment, wrong development. But yes, some people do get born with hereditary anosmia, an inability to smell, because the olfactory epithelium did not develop, it did not evolve in the area, in the regions of the roof of the nasal cavity. The nasal cavity itself is again developing from the face. We remember development of the face, how it happened, and how two halves symmetrically fused in the midline. So at that time, first the normal epithelium is the one which is going to get laid down, and out of that a special development epithelium will develop. So wherever special sensory apparatus or a special neurosensory, neuronal like apparatus develops out of the local ectoderm, we call them the placodes, and we'll come to those terms when we see eye and ear. But remember, there will be an olfactory placode. There isn't one for gustatory, but we will look at the otic placodes for hearing and the lens placode for the eyes. So we will see that later. But do remember that we are supposed to cover development of the special senses also. Apart from this cursory mention, I'm not going into the details for smell and taste. General sense comes under development of the integumentary system, specialization of how the different layers of epidermis and dermis develop, out of which in the epidermis we are looking at only the development of the cell layers which make up thick and thin skin, glabrous and hirsute skin. But it's in the dermis that you have the sensory nerve endings, and that is a connective tissue domain, which is developing just under within the sclerotome, along with the sclerotome of the somite segments. But that development of the integumentary system and its specializations into hair and into nails is a separate subject. We don't have time to devote to that, but these two, hearing and vision, we will look at in detail. So let's come back to corpus callosum. We had talked about development of the prosencephalon, and we said its farthest part, most cranial part, was called the telencephalon, and in that there were two hemispherical developments as they budded off on the left and right side of the central canal, the neural canal, once the neural tube closed. So those two symmetrical halves on either side developed a great deal of neural material, gray matter and white matter, and at such a rapid pace that it grew much faster than the developing cranial cavity, the mesenchyme, which was undergoing ossification to form the cranial vault bones. So the whole developing brain mass, neural mass, folded on itself, craniocaudally as well as side to side, and formed two quarter spheres, not hemispheres, together they are a hemisphere, two quarter spheres on either side of the central midline structure, which remained as the diencephalon. So diencephalon plus telencephalon is equal to prosencephalon, that's how it was. So this diencephalon in the middle, its central canal became the third ventricle, and two offshoots of that, the extensions of that, became the lateral ventricles of the left and right cerebral hemispheres. In the middle of this, the connecting tissue surrounding that central cavity, which is now becoming a slit called third ventricle, and two curved comma-shaped cavities called lateral ventricles, the immediate surrounding area of that became gray matter, neurons, multipolar, which were going to form the deep nuclei of the cerebral hemispheres, and their processes became the white fiber matter. And then one whole bunch of neurons, zillions of them, millions of them, migrated out of this central gray group onto the outside of the white matter and became the cortical gray. That's a huge step in evolution of the central nervous system as we go up the animal kingdom, the vertebrate kingdom, the primates, and then when we come to Homo sapiens, this huge burgeoning of neural tissue is the hallmark of higher evolution. And to do that, to accommodate it, the central gray right outside of the ventricular area, outside of the ependyma, is not sufficient. So there's a whole lot more cells, and they migrate out of the white matter and form a whole bunch of cortex on the outside. And we saw last time that lack of sulci gyri formation, etc., can happen. Agyria, partial regions, different names. We said holoprosencephalon. We had a lot of clinical names. I'm not going into that, but I'm bringing you back to the central area where, when this divergence has happened, the central area immediately on either side of the third ventricle, the gray matter, becomes the diencephalon, which is the thalamus, the hypothalamus, epithalamus, metathalamus, those areas. And over and above that, just on top of that, this left and right connected area of the ventricle develops a white fiber bundle band called the corpus callosum. So what we see is that this crossing of the midline is happening around the 12th week of gestation, and the anterior sections are developing a little earlier compared to the posterior sections. So 14 to around the end of 4th month, and the next one is around the end of the 5th month of development. This middle mass, massa commissuralis, is the fusion of the margins of the groove that separates the primitive telencephalic vesicles. So when the vesicles are separating, that is happening because of a groove which forms between the two of them, and the margins of the groove fuse and get laid down as this massa commissuralis. Again, from the rostrum to the splenium is the progression of development, but there is another theory that it begins in the center and grows in two separate directions. Finally, when the baby is born, that does not matter how it started and how it progressed. But sometimes an insult at a particular area at a particular time of pregnancy may explain defects in corpus callosum. So that's why we have these two theories. But what you remember is that what is happening is a fusion of the margins of the groove that separates the primitive telencephalic vesicles. So this is a properly formed brain, and we are seeing that there is a anterior end and a posterior end, and you differentiate that by this is much more convex and this is more acute angle, right? This is the back side, this is the occipital pole, this is the back, the cerebellum. So in the front, what we have is the rostrum, the genu, the body, and the splenium of the corpus callosum, and on top of that is a cingulate gyrus. You remember this, and there is a thalamus over here, right? And underneath of the corpus callosum there was a septum pellucidum separating the left side and right side lateral ventricles, and there was a fornix on the lower free margin of that septum pellucidum, which was a white fiber bundle related to the limbic system or the limbic lobe, the 6th lobe of the cerebrum. So this is just a recap of where the corpus callosum is when it is normally formed and what are its parts. So what can happen? Agenesis can happen. The corpus callosum doesn't form at all. That's in a very, very small percent of general population, and about few percent of developmentally disabled people, a higher percentage, show an agenesis. There are two I'm not going into theories, this is more of a postgraduate subject, but remember the word Probst bundle may come up. It's a longitudinal bundle of fibers along the medial wall of the lateral ventricle. That may be the only remnant of corpus callosum visible or available, and that does the job, the function of the commissural fibers, which the corpus callosum is supposed to do. So there can be a complete or a partial agenesis of corpus callosum. So when there's a complete agenesis, can you see you have a gyrus, and it's also associated with some amount of sulci-gyri difficulty, but it is not part of a gray matter development of the two cerebral hemispheres, right? It's a separate development and independent of it. So you're seeing that there is no fiber bundle separating, and the gyri are radiating straight up from there. In this one, there is non-formation of the cingulate gyrus also. So the complete agenesis, if you see a coronal section, you're not seeing a corpus callosum at all, but instead you're seeing a bundle of fibers which seems to be there on the medial wall of the lateral ventricle. This is a coronal section, and so you're seeing the parietal lobe, and this would be the temporal lobe, and you're seeing the aqueduct of Sylvius in the midbrain at the same coronal level. And you're seeing the inside white fibers are continuous, but there is no separate bundle of white fibers overhanging the diencephalon or the brainstem, but you have some bundle of white fibers there. So when you have partial agenesis, you can have the beginning or some bit of formation, but the rest of it doesn't seem to be visible. So some bit may form and the rest may not form. Difficult to define actually. These I must acknowledge Bindu ma'am, our HOD. I have borrowed these visuals from her dissections. So that is as far as corpus callosum is concerned, and you can have partial or complete agenesis, and you remember this item called Probst bundle. Then you have ventriculomegaly. We had talked about development of the ventricles. So if a ventricle, lateral ventricle, is highly enlarged, it's because of lack of drainage of the CSF outside the ventricle, which means some difficulty in the formation of the foramen of Magendie and Luschka, so that there's no draining into the subarachnoid cistern behind the fourth ventricle. So then when you do a dissection, you see the white matter and gray matter is so thinned out because of the pressure of the CSF, which is continuously being formed but is not able to drain. And so the child will have severe cerebral matter malformation because of the way the development has progressed. This is very extreme. This is little less pronounced. So you still have some brain development outside of it. But imagine, it's got nothing to do with differentiation of neuroectoderm. It's simply a pressure phenomenon, and still development gets completely affected. So if the baby is born, it is not compatible with a very long life. It will have a severe hydrocephalus, and we have to figure out what exactly happened. And what we can do sometimes when it is not too severe and the baby is still alive and all other systems are all right, they're doing well, is to create a shunt between this fluid inside and some other cavity which can drain it. So they do ventriculoperitoneal shunts, and there are several modalities of doing that. So basically the child is born with a hydrocephalus. The antenatal diagnosis would be hydrocephalus. It can be picked up by an ultrasound examination of the unborn baby when we do the antenatal examination of the mother, and we rule out other possibilities, other causes of the hydrocephalus, but one of them is a ventriculomegaly. Another one, and much more common one, is a lack of arachnoid granulation. So the CSF doesn't drain from the subarachnoid space. The ventricles are fine, ventricles will be normal, this will not be the case. But once the CSF has come out into the subarachnoid space and cisterna magna and then circulated upwards, there are no arachnoid granulations parallel to your sagittal suture. There's no drainage from CSF into venous blood in the sagittal venous sinus, and therefore there is an accumulation of CSF on the surface of the brain, and that can also give rise to a very large head, again a distended cranial wall, separation of the sutures and all of that, if it has, because it's a non-development of structures of arachnoid granulations. There is no cure as such. You can't create or artificial thing you can do, but you can do shunt operations to make a conduit for the CSF to drain. So I'm just spending a little time on this because there are things which can be dealt with even in we are coming to the end of the entire embryology portfolio. We've seen general embryology, you're seeing systemic embryology. Very many places we are not able to do anything for the individual. If the baby is your patient, there is not much you are able to do when there is a congenital malformation defect. But in very many places there is amelioration, there is comfort management where you can relieve that pressure, you can allow some semblance of life, but you can't bring back complete normalcy. You can't replace or recreate brain which was not able to form, and so on and so forth. So those decisions are taken on the clinical side as early as possible when we detect it in the unborn baby. At that point, the mother is your patient, and the priority is to give her the best informed choices of what is possible, why this must have happened, what is possible before the baby is born and after the baby is born, what they can expect in terms of quality of life. And then accordingly, we take the next steps of what is possible. Okay, so let's move on to cerebellum. I talked about the development of cerebellum with the Raman Keflon in the last class. We just look at defects of that. So when the cerebellum is hypoplastic, you have a very minorly developed cerebellum, very, very small compared to the size and development that should have happened by this stage in the development of the CNS. So when one of the things which we notice and which are commonly seen is called the Arnold-Chiari malformation, where there is the cerebellum by itself in its own internal development, there's no mistake, but there is a downward push because of something else which is happening above it. So this is the CSF drainage, the arrows, the light blue space is the subarachnoid space into which from the ventricle the CSF has drained out through the foramina. It's come into the outside space, the subarachnoid space, and it's floating around. So in this particular case, there is a block. It's not able to drain about much. So this space has been increased, and that pressure of the fluid drives the cerebellum downwards, and there's an obliteration of the cisterna magna. So there will be no possibility. So there will be an associated hydrocephalus, and there will be a hypoplasia of the cerebellum, not able to develop much more. So just a name that this can happen where you do not have development of the cerebellum as a secondary, as an effect of something else, some other malformation. So that is rhombencephalon is basically the cerebellum. The synapse is fused. There is no development of the vermis. Remember that we talked about vermis and hemispheres development. So the vermis has not developed as a midline structure. Then you have the fusion of the two cerebellar hemispheres. So just introducing you to the clinical names, which are of embryological origin. Rhombencephalosynopsis is together it has developed. Now let's come to today's topic, which is development of the special senses, and we will go with the eye. So you already remember parts of the eyeball, I hope. We've done the head and neck some time back. But you do remember that there is an anterior part which is closed. These are the eyelids, right? And you have the anterior part. So this was cornea, this was anterior chamber. This was the iris cornea, the iridocorneal development, the uvea, right? And then behind that was the lens, and then it had its suspensory apparatus. It's just simply labeled sensory ligament here, but it will consist of muscles, constrictor and dilator pupillae, right, and ciliaris muscles. And behind that is a huge space filled with a gelatinous substance called the vitreous humor, and the whole lining of that is the sensory tissue, which is critical in the eyeball, which is the retina. Now in that retina, the innermost is green here, the sensory retina, and then outside of that is a choroid, and outside of that is a sclera, and there is a fovea optic nerve blind spot. You remember all this. So how does this development take place? So this, if you take a section of the developing head end of the baby, you have the forebrain, right, and you have the diencephalon behind it, and from it is budding out an optic vesicle. So they're not shown. This is the surface skin, right? This is the surface skin, on not yet skin, but the ectodermal region on the outside of it. And this neural tissue budding out from the CNS neural tube goes and abuts on this ectodermal tissue, which is the outside surface of the head end of the embryo of the fetus. And we have a approximation of neural tissue and ectodermal tissue. This inside out budding is called the optic vesicle, this one, and this outside one is called the placode. So you have the lens placode, which is a thickening and condensation of ectodermal tissue, which will invaginate under the surface and become it will in the form of a cup, like a hollow item, which will close upon itself, and the surface will close outside of it. So then you have a lens vesicle separating itself from the surface ectoderm, and this will invaginate and will push into the tip of this out bulging optic vesicle, converting that optic vesicle into a cup shaped structure, pushing its outermost convex. To begin with, it would have been bulging like a convex, like this, like a convex edge. But when something is pushing it from here, it will become concave, and it will become like a cup. And this cup-like structure is the one into which the lens bulges a little bit more, pushing it, converting it completely into a two-layered cup with a little bit of a space, intraretinal space it is called, which stays for some time, but last at the end is completely obliterated. And this the ectodermal tissue thickens, and lots of layers of cells differentiate and form, making this into a thick, but still it is hollow lens vesicle. It is still, we'll still call it a lens vesicle, but it will condense and thicken and dehydrate and become a solid structure pretty soon. But this is the location which it occupies at the tips of the opening of that cup, at the edge of that cup is where this thick lens material will go and sit. So if you look at it inside view. You get a cut section of a hollow but very thick ectodermal structure and a hollow but cup-shaped neuroectodermal structure, a neural structure by this time. So this is an actual slice of an embryo, right? So you're actually seeing there is a cavity of the forebrain, then there is a budding of the optic vesicle, and this connecting bit to the cup is called the optic stalk. And the cup itself will show that there is an inner layer of tissue and an outer layer of tissue. This inner layer of tissue is multiplying super fast and becoming the nervous layer of the retina. And this outer one doesn't differentiate too much, but develops pigment and is then destined to become the pigmented 10th layer or first layer of the retina. So you see that this is the outmost. As far as light will enter from here, right? Because this is the surface of the, this will probably become the eyelid, isn't it? And outside of this or inside of this is the lens. So in terms of impact, what we remember from the adult eye, its structure and its function. Light will impact this layer first. These are the neural layers, right? And this layer last, which is the pigment layer. So, but we number it. If you remember histology, we'll look at histogenesis for a second. This was the pigment layer, first layer. And into this were embedded the processes of the rods and cones. So that would have been the outermost of the neural layer. And then there was another layer, and then there was a synapse, and then there was the whole bunch of middle layers where interneuronal synapse is happening. So then you have the rod and cone, the sensory neurons, then you have the entire bunch of amacrine cells, horizontal cells, you remember all those cells which are there in the middle, and then you have the ganglion cell layer, third order of relay, and from the ganglion cell layer the axons which come out will become the fibers of the optic nerve. So in development, that is from inside to outside, right? Out of all those layers, the one layer which is separate is the pigment layer. It doesn't have any neuronal component, whereas this one, which was single layer to begin with, becomes many layers thick and differentiates into many types of cells to give that sophisticated, complicated architecture of the retina. And therefore the altogether, it's called the nervous layer of the retina. The lens is developing separately, but the phenomenon of an external item pushing at and abutting on an internal item, and both of them stimulating each other to develop further. The process is called induction. Bindu ma'am might have talked about it in detail in many other areas of development, but remember that's extremely important. If the lens plateau doesn't develop, even the optic cup will not develop the way it should, though they are independently developing under genetic control. This induction is a very important phenomenon for rapid specialization and coordination and synchronization to form a singular multi-tissue organ which has an extremely sophisticated special sensory function. So remember the names. From the cavity of the diencephalon, you had the budding off of the optic vesicle, and then when it abutted on the surface, further development took place. The connecting area from diencephalon remained as the optic stalk, which is becoming a narrow tubular structure connecting to the optic vesicle, which is converting into an optic cup, which becomes two-layered, an outer and an inner layer. The outer layer multiplies much faster, forming the nervous layer of the retina. The inner layer, this I'm saying from the point of view of direction of light, right? But in terms of the optic cup, this is inner and this is outer. So let's not confuse it, just call it pigmented layer and nervous layer of retina, and remember the nervous layer is towards the lens, and that is the one which is developing much more and to many more layers and many more types of cells, and neurons are multi-connecting with each other in all those 10 layers of retina which we saw in histology. So the lens, if you look at it 3 dimensions, this is a cut section, right? And this is forebrain and this is optic stalk. So this is the front end, the back end, these are the 2 lateral sides of the head end. So it's a transverse section. At that point you can see both the 2 lens placodes and the 2 optic cups and vesicles developing on the same plane, only if you take a transverse section. So if you look at it from the outside surface as a 3D picture, you have a solid lens placode invaginating in, and this whole thing is a hollow optic cup with a central canal. It has a central canal, and the groove remains between. It's folded on itself. It hasn't closed yet. So this groove is there to bring in the blood supply, and that will remain as a choroid fissure. We will look at that as when we see the next stage. So what we have is, from the forebrain, a budding out of the optic vesicle. You have a lens placode on the surface. This is what it will look like if you do a dissection from the top, where you've got the CNS developing inside, that is this tube, and you've got the ectoderm on the outside, which is the surface ectoderm. So this is neuroectoderm and this is surface ectoderm. And if you take a section, this is what it will look like. This is one way of depicting it, so you understand the 3D nature of what is happening at this point. So optic vesicle, lens placode, if you remember these two other terms you need to remember. So this is again a little more detailed, but again a way to show that this material of the optic cup, this surface which is going to invaginate it inwards, is going to form the retina, the ciliary epithelium, and its connection is going to be remaining as the optic stalk at that stage of optic vesicle. When it becomes a stage of the optic cup, that's when the lens placode has already come and got related to it and inducted it. So then you see that the zone which is going to become the iris, the ciliary body, that zone is going to remain on the periphery, and the posterior 4/5, 80% of this layer is blue, will become or differentiate into the retina. The entire pigment epithelium part will remain on the top, so it will relate, the pigmented layer will relate to the iris, so we know it is a colored part, and then also to the pigmented layer of the retina. So there's a continuum of that outside layer of the optic cup, but the inside layer further differentiates into 80% and 20%, and that smaller amount will become the ciliary body, the uvea, which will impinge on and relate closely to the lens and actually suspend it and operate it. So this tissue, this bunch of cells, differentiation is very different from this bunch of cells. These are not neural in nature. A lot of mesoderm will happen here because muscle has to form, ligaments have to form. A different kind of structure will be happening there. Only the blue layer becomes neural in nature. So you can see that the pigment epithelium continues, then you have the retina itself, then you have the ciliary zone, then you have further differentiation into different zones. So the green, the tip of it becomes the iris, then the yellow part folds on itself. It corrugates on itself because it grows very fast but does not change its total proportional area of the layer. So it folds on itself and remains as a folded area. That's called the ciliary epithelium, and then this would be the muscles, the muscular area, where they will connect to and operate on the uvea. So only beyond that, the rest of it will become the retina. So in a mature eye, that is the differentiation. 4 different kinds of tissue, 3 different kinds of tissue forming from the anterior segment, and 1 uniform neuronal tissue forming from the posterior segment. So in an embryonic eye and in an anterior mature eye, that's the differentiation which takes place. It's easy to draw a diagram, easy for you to reproduce in an exam. Same thing, nothing different. Surface ectoderm, mesenchyme, neuroepithelium. So here we are giving some more visual to the mesenchyme. So between optic vesicle and surface ectoderm, there's a whole bunch of mesoderm anyway available. It is occupying that area, but it will contribute to the mesenchymal layer outside of the optic cup, which logically should become the choroid and the sclera. Right? That is the contribution of mesoderm to the eyeball and holding it all together. So the yellow areas will be that. Whereas from the green itself, further differentiation has to happen for different parts of the posterior interior layer, most of which is posterior, and a little bit of it is anterior, which will be related to and operating the lens itself. So the lens to begin with is a surface thickening called a placode, and then it invaginates itself, becomes a lens vesicle, then it solidifies and becomes a lens, at which point of time the surface closes around it and becomes a continuous surface, which will in the future become something ectodermal and something completely separated from this ectodermal item, which has become very deeply placed. And over and above it, anterior to it, we'll have to develop the anterior chamber and the cornea, the conjunctiva, and then the eyelid with the muscles embedded in the eyelid. All of that will come from this blue and a little bit of yellow, which comes here and contributes to the musculatures of the eyelid. I think this is a neat diagram to use. So you have the lens, then this will become the future vitreous humor space. There'll be 1, 2, 3 layers of retina. So the outermost will be the photoreceptor cells, the middle one will be the interneurons, the third one, as I mentioned, will be the ganglion cells, and their axons will get out to the optic stalk, which will become the optic nerve. But the optic stalk was hollow to begin with. It was a cylindrical outpouching, and that hollow will be occupied, will be invaded by mesoderm, where vascular development will happen, and the choroid artery, this which becomes the central artery of the retina, will develop and persist and continue to nourish all the layers that have been formed. Okay, histogenesis, you don't need it anyway, I've talked about it, but same thing, epithelial cells, a layer of pigmented cells, and then a layer of, where are we? The epithelial cells are on the surface of it, so your pigmented cells have gone deeper inside, and on the inside of it, you have the multiplication of the orange layer, giving rise to the neuronal epithelium, neuronal tissue, and these orange dotted ones are going to remain as the outer layer of the optic cup, and that's where the pigment deposit will take place, and therefore they are called the pigmented cells. So the orange is, if it's the orange is a pigmented layer, then the inside one is a neuronal epithelium, and both of them are fused, leaving no space in between. But to begin with, there was space in between. The cavity in front of these two layers of optic cup became water filled, liquid filled, and then broke down completely, and that the gel which filled up that cavity later will become the vitreous humor. In front of that, the lens has invaginated and been absorbed and closed. So the lens and the ciliary apparatus is there, and the vitreous humor is in the back compartment. In front of this, between this and this, a compartment develops in which there will be an aqueous humor and there will be an anterior chamber development. But this will have nothing to do with this optic cup. Just remember that. In front, whatever is happening in front of the lens has got nothing to do with development of the optic vesicle and optic cup. Okay, so there are anomalies of the eye that can happen. It's a complicated development. It should be bilaterally symmetrical. There should be two lens placodes which are invaginating from either side. But I'm sorry I didn't have time to create a slide for anomalies. I want you to do that as a homework. If you understood how the eyeball has developed and how its different layers have been differentiated out, then you should be able to understand that there may be non-development of any part of this. So a lens placode may not develop, one optic vesicle may not develop, and then you'll have a congenital absence of the eye. But I'll tell you some names. It's there. I'm reading from Langman's embryology, the clinical terms which are used with non-development of the eye. So a total complete agenesis of eyeball kind of thing doesn't usually happen, but some portions of it may not develop. Asymmetry may happen, or because of other related difficulties at the same time of development, you may have a fusion of the both sides, forming a singular eyeball in the center. where there is no separation because there is no development of the central part of the face. So this is a development of face defect. It's got nothing to do with the two lens placodes and the two optic cups. That is happening very happily inside. But they are coming together. They in terms of development of the face, which is happening around it. These two placodes from very lateral positions come usually to occupy somewhat central positions. But at that point, in the development of the face, the mesoderm here is being laid down as a central column of tissue, which keeps these two developments separated. Normally, if that doesn't happen, then these two lens placodes will keep getting pushed closer to each other with the eyeballs behind them. And the rest of the face development will be mistaken, and so you get this situation or a phenomenon called the cyclops. You can have a baby born where you have a sign of ophthalmia. The two eyeballs develop, but in a stage of their development, they are pushed so close that they fuse and form a singular item which looks like a eye, which may or may not be a functioning one, but that will be always associated with a difficulty or a mistake in the formation of the nose. So there will be a proboscis like appendage which will develop, which will not really differentiate into the two nasal cavities with the central septum and all that. And inferior to that, you will have the formation of one singular surface item which looks like cornea and lens, behind which there may be a singular vesicular or globular neuroectodermal tissue which would not have developed perfectly in any case. But in the baby's face or in the baby's scan, sonoscan, we'll be able to see that there's something seriously wrong here, and the primary defect is not with the special sensory apparatus, but rather with the development of the face, which didn't allow a separation to remain between the two eyeballs. So anyway, the clinical name you need to remember is cynophthalmia, fusion of the two eyeballs, and cyclopia or cyclops. There was a Greek story of an island with creatures, human-like creatures who had singular functioning eyes in the middle of their forehead, and that's all legend. That's a story. That's an epic story. But because of that, the name of this condition is called cyclops or cyclopia, single eye. And there is a spectrum of defects which will always be associated with it. Anophthalmia is the absence of an eye. That can happen. Then you can have aphakia, APHAKIA, which is absence of a lens, absence of development of the lens because of a placode difficulty, and iridia, a lack of development of the iris, which is the anterior 1/5 of that inner layer of the optic vesicle, optic cup. Then you can have microphthalmia, very small, poorly developed eyes. It may be only about 2/3 of the volume it is supposed to actually have. You can have congenital cataracts. You can have opacification of the newborn baby's lens for various reasons, one of which is the mother having contracted rubella, German measles. So there are certain infections which a mother may not herself suffer too much from. The unborn baby will be severely impacted, especially in terms of its congenital development, and therefore it will result in congenital anomalies. The ones which we are more worried about are heart anomalies, kidney anomalies. Heart is very frequently impacted if the mother has these infections. Later in clinical medicine, you will learn them as torch infections, toxoplasma, herpes, and so on and so forth. You come to that when you come to that. But one of the things which it can show in the surface, easy to examine in the baby, is a congenital cataract in the baby's eyes, which we can see. This may or may not show up in a scan because the baby's eyeballs and its lens may or may not be able to pick it up, but it will immediately show up at the first clinical examination. It's usually associated with other anomalies which may have been picked up antenatal. Remember, congenital cataract can happen, and this is because of this rubella which can happen between the 4th to 8th weeks. Now this whole lens placode thing was happening on day 22, which is how many weeks? 5.5 weeks. So somewhere between 5th to 7th week, if the mother is having a first trimester infection, we have to be very, very careful. If it's an exanthematous fever, we are really worried, because then if it is one of those which impacts the fetus, the mother will come out of it. She'll just have a small fever and a rash and a little respiratory cough and things like that, and she'll recover. But the baby is incurably impacted. So we are very, very careful with first trimester of pregnancy, particularly this 5th to 8th week, because we know the entire CNS is proliferating rapidly, but special senses too are particularly well differentiating very rapidly. Then we can have defects in the formation of the whole structure. So in the whole iris, you can have one defect, and that's called a coloboma. C-O-L-O-B-O-M-E. You can have a coloboma of the iris. You can have a coloboma of the iris and the eyelid on top of that. So these are genetically related, because these differentiations are happening via the orders of a bunch of genes, which only unveil or direct development of this, both optic cup and the lens placode. So one or two genes are missing or not able to express themselves. You may have correlated defects in two different tissues which are differentiating at the same time. So remember, coloboma of the iris, and this may very often be associated with renal defects, because the genitourinary system development of that same age of fetus is also impacted, probably by closely related genes. So these would be genetic determined congenital anomalies. So I think developmental difficulties of the eye I have already finished, and we'll move on to the ear. You remember this diagram? You would have done it with pharyngeal arches. So just to remind you that a whole bunch of derivatives of first pharyngeal arch are going to contribute to your ear apparatus, and another whole bunch comes from the second arch. So here what we have is the first arch we know is contributing hugely to the development of the lower part of the face beneath the mouth, and the posterior end of it, the posterior lateral end of it, extension, is going to occupy the future middle ear area and contribute to the ossicles, and also from the second arch, which is contributing to the styloid bone, its ligaments and muscles, and a little bit into the middle ear. So just remember that this was called Meckel's cartilage, this was called Reichert's cartilage, and there were ossicle developments from the pharyngeal arches. We will recapitulate later. So again, back to the story of placodes. So at the same time, near about the same time, on the sides, not as cranial as the lens placode, a little caudal to the lens placode. At that place, the developing head end of the embryo is wider. The two otic placodes are also formed, again on the surface. So I don't have a picture, do I? Okay, don't have a picture. I'm sorry. Okay, so try to imagine the head end of the baby with this bulging cranial end, and at the more cranial, because the prosencephalon is developing in front, at the diencephalon level you're seeing the lens placodes, and then you're also seeing a little caudolateral to that is the development of two more placodes, which are called the otic placodes. So this is the surface ectoderm thickening into a placode. At the same time, the neural tube closure vagara is happening. This placode again dips in as the otic cup and then closes and becomes a closed hollow structure called the otic vesicle. And some amount of neural tissue differentiates here, this neural tissue, from the neural crest, which was developing here from the dorsal posterolateral edges of the closing neural tube. So this age of development is a little earlier than what is happening over there. Because forebearing vesicle and all that is happening a little later. Here it is almost just immediately after closure of the neural tube, and you have the little bit of migration of neural crest cells which come and form a neuronal bunch of tissue just medial to or between the otic vesicle and the surface of the brainstem. This is the brainstem. You can see this is the thinned out part, posterior part of the forming rhombencephalon, right? The lower part of pons and the upper part of lower part of future pons and upper part of future medulla oblongata. In that region, is where this neural crest migration has formed a small multineuronal patch, which is lying very close and adjacent to this otic vesicle. It is not part of the neural canal. It's already differentiated and separated out from it. Remember that the source is neural crest. It's partial only. This will form a neural crest forms ganglia. So it will form the ganglia associated with the hearing apparatus. We will look at that. So from the surface, an invagination will happen. This is the placode part. Okay, see the differentiation in color. This placode has come inside, become an otic, not optic, and it is from the placode side. For the eye, it was lens placode, right? And it was optic vesicle was from inside, right? This is otic. The placode is called otic. Remember otic ganglia. I don't think there's anything to get confused about because they are different developments. Sometimes you all are careless in your answers and write optic for otic and then you won't get marks. So just clarify it in your head, separate out the spellings completely. Otic is about the ear and optic is about the eye. So coming here, we have the otic placode going back in, becoming a cup, becoming a vesicle, and this thing is becoming longish. It's going to elongate and form a very complicated shape. We will go into that. So to begin with, it seems to form two bulgy oval shapes and one long tubular shape, and it's coming to lie pretty close to the neural tube, which is rapidly multiplying, of course, by this time, and that neural crest separation thing would have been in somewhere in this area. It's not there in this diagram. At this same time and same place, the surface ectoderm, not the part which contributed to the placode, the adjacent part, invaginates inwards, right, and forms a tubular canal-like structure going inwards. At the same time, just behind this neuroectoderm, there was a notochord in the midline, there was a neural canal, and behind it was a developing foregut, right, the most cranial part, which will come and stop at the buccopharyngeal membrane. If you go a little later, the future pharynx area is still foregut. At this time, we have not given it any other name. That is giving a outpouching from the pharyngeal pouch. This surface one was forming pharyngeal arches. This one is forming pharyngeal pouches. The arch and the pouch are approaching each other because of this diverticulum formation from inside and a crevice formation from outside. So the outside surface is bulging inward and the inside tube is bulging outward toward each other, and that is the place where they will approach each other. And the mesoderm in between, this is ectoderm, this is endoderm, and the mesoderm in between will start condensing and differentiating and forming shapes and different structures, which will contribute to whatever is there between these two areas, and will attach and relate to these areas to form the future ear materials. So as can be guessed, this side will form the external ear, ending in the closed outer surface of the tympanic membrane, and this one will form the pharyngotympanic tube, what we call the auditory tube or the eustachian tube. It will form the continuous connection, and it will push itself out into a space which will form the middle ear. So this whole mesoderm first condenses into all the solid items, and then between the solid items, spaces, the vacuolation happens and tissue disappears, creating a space to which this space will connect. Right? That's how the middle ear communicates anteromedially with the pharynx. Right? In a coronal section, you can't make out antero, but you can make out media. You can't make out antero and posterior. But this is diagrammatic, of course, schematic. But try to understand that is how it is happening. And on the inside of this, there will be a limit or something. And to this end of that mesoderm differentiation, this thing will come and abut. It will come and approximate and touch. So the inner ear is coming from all of this, right? The outer ear is coming from this, and the middle ear is coming with components from here and whatever is remaining between this thing and that thing together. And these three completely different developments are happening so beautifully coordinated that together the apparatus will conduct vibration sense into neuronal stimulation, electrical impulses. Extremely sophisticated and therefore very, very vulnerable to injury or mistakes. So what we have, if you just look in terms of tissue, is you have mesoderm on the inside, on the outside you have an ectodermal branchial groove, first pharyngeal groove, and then you have, I think this arrow was supposed to come to here, I'm sorry. The eventual tympanic membrane and malleus will be developing in this area. And the endodermal primitive tubotympan, these were the names in the old editions of Gray's Anatomy. The ecto, of course, but ento, this spelling we don't use anymore, but that's how they used to call it, the primitive tubotympanum. Tympanum is the middle ear, and the tube is the auditory tube which is connecting to the pharynx. So it's essentially just a tissue differentiation which is happening there. So what has happened on the inside is, with that long tubular structure, which was originally the otic placode, that which got buried deeply inside. We are now looking at middle and external ear. You're only looking at internal ear, paying a little more focus on that. So what we are seeing is it differentiates into a ventral area and a dorsal area. This is ventral. The ductus cochlearis becomes the extension of it ventrally. The dorsal one remains as two central areas called utricle and saccule and get extended into a ductus endolymphaticus and into three budding outs which become the superior, lateral and anterior semicircular canal, the semicircular ducts. The ganglion is on the medial side of it, remember, which came from neural crest, and that becomes the ganglion cochleaire, which is a spiral ganglion which will serve the organ of Corti. This is very blurred, I'm sorry, but just to show this, blue is external ear, the yellow is middle ear, with differentiation of the red mesenchyme in it, which form, this is the bony parts, is the stapes, and this blue is coming from your buried and rapidly differentiating otic placode. So to begin with, a neural tube, and very difficult to understand this. Probably this is easier to understand. So this is the outer three-dimensional shape. This happened first before the neural tube was closing. Then when the closure happened, some areas remained not changing much, but other areas bulged out, and the anterior part became the cochlear pouch and the posterior part started differentiating. So if you look at the surface, it's differentiating into three triangular areas. This becomes a cochlear part, and this becomes differentiated into a stretched out area like that, in which three things are developing simultaneously and separating out. They are all looking connected to begin with. Then the middle areas disappear, forming these gaps, so that what remains of the tissue is only the semicircular canals with one bulging end, which is the, we know this, the ampullary end, right? And two of the stems fuse, so you end up having 5 connections to the utricle saccule area with 3 ampulla visible and connected. The color differentiation is just to show you, is from the same apparatus, 2 different neuronal territories are developing. The pink one is for vestibular and the yellow one is for cochlear. So this is hearing and this is balance, which is happening at the same time from the central area. So yellow is hearing and pink is balance, differentiating out from the same bunch of neuronal tissue which is differentiated. So finally you end up having a vestibular component coming away from the utricle and saccule and the cristae inside. Remember, there's crista ampullaris and all that. And you have this organ of Corti, which is the spiral ganglion on the 2.5 turns of the cochlea, the neuronal tissue which is differentiated out and which will contribute to the cochlear part of the vestibular cochlear or the 8th nerve. So because we are running late, I will just I'll just give you the names of the defects which can happen. Hearing loss, deafness, can be of a conductive nature or a sensory neural nature. That could be because of any mistake happening in this coordination and coming together. And again, many of them are associated with prenatal infections. The first one I mentioned is rubella, but also associated with maternal diabetes and premature birth of the baby. The most common ear ossicle to be impacted, not shown here, is the stapes. Right? So formation of the stapes, because some portion of it is being contributed to by neural crest, there is a coordination which has to happen, and that can have a malformation or a stiffness where it attaches to the oval window, and that is why that could be one of the causes of congenital deafness. External ear defects are very common. You might have seen children, babies with funny shaped ears, with awkward looking bits and pieces, because the ossicles are, the external ear, the pinna and tragus are developed from 6 different ectodermal hillocks on the surface, which has got nothing to do with the placode and everything else which is going on inside. And these 6 have to fuse in a particular format to give that typical shell-shaped ear, and that can have mistakes. By itself, it's a cosmetic defect. There's a little distress to the patient, but that's not a big problem. The big problem is it may be associated with external ear defects, in which case there's conduction loss. Or it may not be associated with any functional loss at all, but it will be related to some other system's developmental defects. So when you examine a newborn baby, we carefully look for formation of the, just as we count the fingers and the toes. We carefully look at the external ear. Sometimes the only thing we might see is a preauricular sinus, a small dip from the surface, which is a small indication to us that maybe this development, some little mistake has happened. But we will then conscientiously search for defects in other systems, which are much more vital systems, critical systems, particularly renal. And we make sure that we have not missed any internal developmental anomalies. So many chromosomal syndromes will have manifestations in the development of the external ear, and we keep that as a high suspicion in our mind when we look at the ear development. So preauricular appendages, extra skin tags and pits are important markers for us. Alright, I think I've covered whatever you need to know at this stage. Please look it up, read it up in the book. I have not received a single query from this class. Please send your queries in if there are any, and we'll try to cover it up in revision lessons, which we may schedule. If you are still going to be delayed coming back, we may have to do that. Right now we don't have any plans for doing any revisions for you, but it may happen in future. But as far as we are concerned, embryology is over, and goodbye for now. We'll see if I'll see you again. Bye.